Hi, I am Taha Makaram. Today, me and my group, Farah Sarraj, Fatima Al-Kindari, Shok Thuwaini, Yara Tafish, are going to represent you our project, a simulation study on bed capacity management in a public hospital. For the past few decades, worldwide healthcare systems have been under tremendous stress for failing to plan effectively as hospitals cannot function at 100% bed occupancy. High levels of bed occupancy can affect patient care since it's less likely possible to direct the most suitable bed for the patient care. In a health system, a widespread of consequences may result in lack of available beds, causing an increased rate of infections, inappropriate clinic-ward patient placing, and pressure on staff to clear up beds. In addition, overcrowding and overoccupancy in hospitals are considered as a global crisis and is classified as a national catastrophe in many countries. One of the main factors of overoccupancy rates is the poor capacity planning of beds required. Planning the bed capacity must tackle and take into consideration the reasons and causes that affect the load increase in hospitals. One important reason is the diversions between the patient flow through beds, available beds, and the demand. Whenever the demand of urgent care increases, the bed supply becomes less, flow of patients turn out to be weakened. Additionally, treatment delay due to lack of resources and the absence of medical staff without any reason will cause the increased load in hospitals. Throughout the years, other classifications appeared, such as level of care, length of stay, or urgency, and emergency care units. All the reasons mentioned contribute to the effectiveness of managing the capacity of beds. The following fishbone diagram shows the possible reasons of overcrowding in a hospital. For example, people. There are not enough doctors or nurses, doctors arrive late, length of stay of patients, mismatch in assigning people to beds, and poorly trained doctors and nurses. In addition, equipment is a reason. There are no available beds, lack of resources like wheelchairs, poor maintenance of equipment, and not enough treatment rooms. Also, methods are a reason, where lack of planning and scheduling is happening, poor discharge implementation causing delay, and redundancy in tests. Finally, environment, where inefficient flow of patients is happening, long turnover time, processes taking extra time, and external influences. Let me introduce you to the causes and results of poor bed management. For example, the causes are overcrowding, varying demand, discharge delays, and bed assignment mismatch. This causes poor bed management, which results in long length of stay, long queue length, less patients, increased bed investment cost, and increase in infection rate. Hospitals are under real pressure to cut costs that cause increasing patient access with less bed capacity. Conversely, the capacity of beds should meet the demand of the patients who need care. Improving bed capacity management can improve care delivery. The best solution to have better bed capacity management is enabling increasing throughput to meet the demand because it's the least expensive and the longest term capacity management strategies. Moreover, improving the planning of supplying is important to improve bed capacity management. But the actual number of beds follows the number of patient arrivals and service times. A healthcare system seeks for finding better ways of operating and planning hospital bed capacity for delivering necessary care to patients and allocating beds to arriving patients. Reducing number of beds may have an impact on improving hospital performance, which will result in higher occupancy rates and tighter control of costs. Nevertheless, hospitals are facing major issues regarding its inappropriate number of beds in each department due to overcrowding and overoccupancy. The factors such as infection rates, discharge delays, and admission of patients with incurable diseases make bed management a difficult task. Poor bed capacity management leads to its long length of stay, excessive patient waiting times, as well as lower quality of patient care. As a response to this problem, the project is going to propose a methodology that will improve the bed capacity management process in a hospital in order to assign right patients to right beds, decrease bed investment costs, and deliver a better quality care.
According to the literature review, we have studied many papers that are related to the problems of bed capacity management, such as shortage in resources, long waiting time, patients are turned away, infection bed capacity management, variation in demand, and high occupancy rates. The main objectives of this project are to analyze patient flow, to study processes, to simulate the existing situation in the hospital, to reduce length of stay, to reduce discharge delays, and to evaluate alternative solutions to bed management. Moving to the project stages, there are 5 stages in this project that we followed, starting with identify the problem, analyze patient flow, data collection and analysis, simulate the model, and end up with results and recommendations. In this hospital, we have several departments, which are triage, checkup rooms, vital signs, resuscitation, observation rooms, casualty and operational therapy, intensive care units, and internal and surgical wards. Hospital wards are divided into surgical wards and internal wards. The surgical wards are divided into general, ophthalmic, orthopedic, urology, ear, nose and throat, and dental wards. Moving on to the patient flow analysis. As patients enter to the triage room from the emergency department, they will be categorized under the 5 levels according to their severity levels. From that, they will be moved to the other department of the hospital. And this is the continuous of the patient flow analysis. In this project, we have collected many types of data, such as patient flow, number of beds, type of beds, schedule of doctors and nurses, number of cleaners, time of each process, and number of discharged patients.
So after collecting the data, we note that there are 2 types of arrival patient, 2 wards. The first type is from the emergency department, and 61% of these patients are waiting in the observation room in the emergency department because there is no available bed inside the ward. And the second type is the patients are coming by appointment. From this graph, you can see the number of arrival patients in the emergency department for 1 month. From the bar chart, we understand that most of patients are transferred from the emergency department to surgical ward, especially for general surgery ward. However, for patients that are coming by appointment, most of them is going to the general surgery ward as well.
After collecting the data from the hospital and understood how the system works, discrete event simulation is used because it's one of the important tools for modeling complex systems and mimic the behavior of real system. However, before modeling the system, there are inputs and outputs that are considered. The inputs are patient's arrival, number of beds, schedule of doctors and nurses, process times, turnover time, and length of stay, whereas the outputs are utilization of doctors and nurses, utilization of beds, waiting times, queue length, and number of discharged patients. So as you can see, this is our simulation model and how it looks like. We modeled a simplified version of the hospital which consists of patient's arrival, checkup rooms, ICU and observation rooms, internal wards, and all the 6 types of surgical wards. So after modeling the system, we got the base model results. Here we noticed that there are departments with a very high utilization of beds and departments with a very low utilization of beds. This showed that there are departments in the hospital that has insufficient number of available beds, whereas other departments has sufficient number of beds. So in order to solve this problem, OptiQuest is used to make sure hospital beds and wards are used appropriately. National Institute for Health and Care Excellence stated that average bed occupancy rates greater than 85% have the risk to experience regular bed shortages and increased infection rates. However, average bed occupancy rates below 70% lead to excess capacity and unemployment of resources. Therefore, the objective of OptiQuest is to set up an optimization model to maximize the utilization of beds, subject to the utilization of beds to be above 70% and below 85%. Then we got the OptiQuest results. As you can see in this table, the optimization model is conducted for all type of words to examine the optimal number of beds that should be used to satisfy the given constraints. So this table includes the available number of beds and the number of beds needed, along with the current utilization percentage and the optimized utilization percentage. However, some of the words optimization model solutions were infeasible as shown in red, since they didn't satisfy the constraints. Yet the best and feasible solutions that are close to 70% utilizations were chosen because it's better to have capacity than bed shortages. Based on the OptiQuest results that were shown in the previous slide, we noticed a major change with two of the hospital wards, which are the general surgery wards and internal wards. As shown in the graph, we recommend to increase the number of general surgery beds to 112 for males and increase the number of beds to 49 for females. As opposed to this, we recommend to decrease the number of beds in male internal wards to 36 and decrease the female internal beds to 37. Then, after finding the OptiQuest results, we came up with 4 possible scenarios as shown in this slide. The first scenario is improving doctor schedules. Second, adding mobile beds in the observation rooms. Third, reducing the number of internal wards and increasing the number of general surgery wards. Fourth, reducing the turnover time. We applied the 4 scenarios in the output analyzer and found out that improving doctor schedules is the best scenario among the others.
Therefore, there is a need to increase the efficiency of processes and procedures used in this hospital. Suggested solutions were well thought to enhance the hospital performance, showing the possible solutions based on the what-if scenario results. The first point is to reduce the turnover time between admissions and discharges by assigning 2 cleaners at the same time to clean the beds. Concerning about the doctor's schedule, since they play a significant role in patient flow, we suggest to allow on-call doctors to discharge patients. The goal is to increase the number of discharged patients and increase the opportunity of another patient to occupy the beds. Additionally, there are other suggestions which are based on the insights observed in the hospital during the visit. The first point is to expand the observation rooms for both females and males through using the extra beds that were non-occupied in some wards based on the OptiQuest results. Second, we all know that complexity in planning is rising due to the increased day-to-day variations in demand and insufficient resources. Hence, adding a new general surgery ward in the unused and abandoned basement floor will reach the targeted utilization rate and reduce the waiting time of patients in the observation rooms waiting to be admitted. Also, one solution is that patients who are ready to be discharged and must be signed by doctor's approval can be transferred to a specialized room or a dedicated room for this purpose. This will minimize the waiting times of new patients comers to the wards. Moreover, the fourth recommendation is transferring patients with acute and long-lasting medical conditions to residential care centers in order to reduce the occupancy rates in wards. Lastly, another effective solution that will expand their patient base and will serve more patients is to add a waiting time system in the hospital's website that shows the current waiting time in assigning the triage level. This will allow people with non-emergent conditions in deciding of when to arrive to the hospital. This will certainly minimize the number in queue and high congestion rates in the emergency department. To wrap up, the management of bed capacity will have a significant impact on the hospital, meaning that improvement related to bed management will impact the availability of beds, hence improving patient flow. The overall goal of this project was finding the optimal number of beds with an ideal utilization between 70 and 85%. Patient flow and data collection were analyzed. Additionally, through the use of simulation, the operational behavior of the hospital was determined, analyzed, thus solved. Not only that, scenarios and solution alternatives were also provided, and the helpful aid of OptiQuest Arena provided the optimal number of beds in each ward. As a result, the most important change that has been solved is that we increased the number of male general surgery beds by 76.7% and female general surgery beds by 46.9%. Also decreased the number of internal male beds by 65.7% and female internal beds by 64.7%. Not only that, average patient length of stay reduced from 10 days to 3.5 days, and Total number of beds in the hospital reduced from 336 to 287, which is a 17% decrease. The hospital has great challenges and great opportunities, and implementing this solution will surely meet high and worthy outcomes, where they expect that the implementation of this plan will result in superior healthcare delivery system. On behalf of me and my group, I would like to thank the Industrial Engineering and Operation Management Conference for giving us the opportunity to present our project. Also, we would like to send our regards to our supervisor, Dr. Ufuk, for supporting us and for his guidance towards success. Last but not least, we would like to express our deepest appreciation for the American University of the Middle East for the learning opportunities that were given to us throughout the years of studying. Thank you very much and have a good day.